The following is a conversation with Professor Debbie Shawcross, a clinician scientist and Professor of Hepatology and Chronic Liver Failure at King's College London. Professor Shawcross is a world-renowned expert in the application of intestinal microbiota transfer to treat chronic liver disease, and in particular, a downstream complication of cirrhosis called hepatic encephalopathy. She's been chief investigator and primary investigator in a number of key studies relating to liver disease. This is Inside Matters. My name's Dr. James McIlroy. I hope you enjoy it. What are some of the cool things that are going on right now in your lab?
Lots of cool things. But I think the major focus has been on getting the clinical trials up and running. So just to give you a little bit of background, we undertook the first randomised clinical trial in Europe. So this is outside of the United States, called the Profit trial, which was a clinical trial where we wanted to explore whether using fecal microbiota transplantation in patients with advanced liver disease, so these patients have liver cirrhosis from whichever etiology, and we wanted to understand whether actually changing their gut microbiomes with fecal microbiota transplantation was safe. And the most important thing,
right.
Safe.
Right.
If it was tolerated by the patients, and actually if they like the idea of having it. So one of the things we weren't very sure about was actually whether our patients would actually, go through with having a fecal transplant. It's fine to say, I'll sign the consent form. Yeah, I'll do this. And then actually when it comes to it on the day, would they actually go through with it? And it's interesting because not everybody does.
Okay.
So we designed this small study. It was a 32 patient study where we randomised patients in a 3-to-1 ratio to either receiving FMT or a placebo.
Yep.
But actually, it was a placebo administered endoscopically, like the FMT. So the patients went through the whole process without knowing whether they had the FMT or the placebo. They went through the endoscopy. They went through having the product put into their small bowel,
right.
But they didn't know which one they had.
Wow.
So it was good in the sense that there's a criticism that many of the US studies that used fecal microbiota transplantation, they had standard of care. So people knew they were getting FMT and automatically felt better because they knew they got FMT versus those that were just being followed up in the clinic and not.
And when we say standard of care, we mean like the best available treatment?
Yeah, best available treatment. So, seeing their consultant in the clinic and having the usual medications that are prescribed to people with liver disease and being followed up, but not actually having any definitive treatment.
Right.
Okay. And there's definitely, when you're given a medication in a trial, there's definitely a positive impact just from being in a clinical trial. So we know that patients on clinical trials do better because
than people who are just in the hospital.
Yeah. Because they think there's hope. We give them hope because they think, I'm in a clinical trial, I'm taking something that might actually make me better. If it doesn't give them personal hope, they have that kind of altruistic kind of hope that even if it's not going to benefit them, it might benefit others with the disease. I think that's really important. But also being in a clinical trial, they're regularly seeing, they're more frequently seeing their doctors, they're more frequently seeing research nurses. They have a telephone number they can ring 24 hours a day if there's a problem.
Okay.
That makes people feel better.
Yeah.
It does, that actually I've got my research nurse on speed dial. They don't necessarily call on 24 hours a day, but it makes them feel better. Right. And, so being in a trial is a really, really important thing, but also having a placebo is also important so that you understand that kind of effect of being in a trial versus the actual real effect of what you're testing.
And the placebo is, for the listeners?
So for the Profit trial, the placebo was just saline, just basically sterile water.
So there was still a liquid going.
Yeah, there was still a liquid going in.
Got it.
So just to help everybody who's listening, so the fecal microbiota transplantation that we used in our Profit trial was a raw stool treatment. So this was the early types of fecal microbiota transplantation where you would get a donor, they would donate stool, which was then processed and frozen. And then what you would do is you would unfreeze it and give it to your patient. It's a volume of about 200 mils of liquid.
So about less than a can of Coke or
yeah,
Amber or
yeah, just a little bit less.
Yeah.
They didn't drink it. What we do is we at the time we did a gastroscopy, which is putting a flexible camera down into their small bowel, and then putting a little basically straw down, and then putting those 200 mils down. So this is not anything that's going anywhere near their mouth, anything that they're going to taste, or whatever. It's going straight where it needs to go, and then they're coming out afterwards.
I think that's probably quite an important point, isn't it? Because when people think fecal microbiota transplantation, or sometimes it's called intestinal microbiota transfer, or even just a stool transplant, they think, oh my gosh, am I going to have to do what? But actually, you won't know, will you? No, you don't know. And it's been well screened, it's been processed in a really tightly controlled pharmaceutical environment. So what you were talking about at the start was people opting out, before they get it. Is that because they're thinking, actually, no, I really don't want that? What are the kind of classical reasons, or is it more because there's a tube going into them?
Yeah, well, it's a variety of reasons. So we actually 32 patients enrolled in the trial and actually went as far as signing the consent form. But actually, we only treated 21 of them for various reasons. Now, some of the reasons were that patients pulled out somebody, and it might be something silly like I've got a new job or something, that's meaningful to them, but it doesn't necessarily make any sense in a clinical trial, but it may have been used as an excuse because they were having second thoughts. But also because we were treating patients with liver disease. Patients with liver disease are quite an unstable group of patients in the sense that they're in and out of hospital a lot. They don't feel very well a lot of the time. And sometimes it was just a simple thing that actually, I've signed up to this, but I really don't feel very well, doctor. I'm not sure. I think this is all a bit much for me. I don't think I can go through with it.
Right.
It never happened in the end. I think one or two people were a little bit alarmed by the thought of, what was happening to them, but many of them weren't. Actually, many of them were very excited by the fact that they were using this new treatment that was not a conventional tablet.
I've heard that before. I've heard patients, they've done a bit of reading on the microbiome, they get the concept, maybe my microbiome isn't so good, and if I get one from a healthy person, then that could have all sorts of benefits.
Yeah, exactly.
And some of the doctors that I've spoken to who work in the inflammatory bowel disease space say that their patients don't want any more immunosuppressive medication. They want a different type of approach, and they're all asking for FMT, IMT, probiotics, so on, so on. So it's really interesting to hear that some of your patients were, excited going into the study. Do you think that moving forward as we do bigger trials, and I know you're planning a bigger one with maybe more refined or easier to administer formulations like capsules, there might be even more patients who enroll?
I think so. And it's interesting because I'm a sort of clinician who's been involved in running lots of clinical trials over the years in liver disease, all different types of liver disease. And I would say that the fecal microbiota transplantation trials are the only trials where I've actually had patients emailing me saying, I hear you're doing this trial, can I be involved? I've never had that before in any other kind of clinical trial.
Wow.
So
that's amazing.
Yeah, it is amazing. And I think there's been a lot of publicity. Channel 4 are, I'm not sure whether you're aware, have got a programme that's coming out in January on FMT. And I think that people are interested. They want to learn more. They want to be part of this. And they will write and say, can I be involved?
Amazing.
Yeah.
So what did you see in your trial?
So the trial was primarily about safety and tolerability and acceptability, those kind of three things. Yep. But what we did is so it was a short trial. It was a 90-day trial where we wanted to make sure that what we were doing to patients was safe. And I'll give you a little bit of context because in the United States, there were a couple of very unfortunate cases that were published, and readers may have come across this, where fecal microbiota transplantation actually passed on a very nasty bug. That we want to make sure that anything we're doing for our patients is absolutely safe and the right thing to do. And I think, in the UK and Europe, we've been much more stringent about screening stools in a very, very robust fashion now. And actually, we screen donors now as if they were donating a kidney or a liver or anything else. So nothing really passes through. But we we wanted to still make sure that in a group of quite vulnerable patients with liver disease, because they get very sick, that it was a safe thing to do. And that was the primary goal over the 90 days, to look at that, to look for adverse incidents. And it was amazing, actually, how there weren't any. Wow. It was really, really well tolerated.
Fantastic.
The things that we did pick up, though, is that patients who do receive FMT get a little bit of temporary gastrointestinal disturbance for a few days after the FMT. And you could say that's a bad thing, but actually, in my eyes, it's a good thing, because actually what it means is that their gastrointestinal systems are changing in response to the FMT. So what's happening is everything's moving around, and the bacteria are changing, and people get changes in their bowel habit and maybe feel a bit more bloated, or things are changing. But it settles down within about 72 to 96 hours, and it's gone. So we picked up that people do get these things. And so I think we learned from that, in any trials moving forwards, we will warn patients, that if you do get a bit of GI disturbance, that's okay.
That's part of the way it works.
Something bad hasn't happened, So we learned about that. And we learned that nothing bad was going to happen. But what we did is used it as an opportunity to collect samples from patients, from all of the patients that were enrolled, so that we could try to understand what's happening to their bodies and their gut microbiome, by having the FMT. And the results are currently being put into a manuscript, which will shortly be submitted. But in essence, what we got was some really, really favourable signals to suggest that it was changing the gut microbiome in a really positive way. And it was giving people diversity to the gut microbiomes. So what happens in liver disease is that people's gut microbiomes become less diverse, and you get one or two populations of really bad bugs instead of having lots of populations interacting together in a positive way. And there are some bacteria that are particularly bad in patients with liver disease that kind of take over their gut microbiome and often result in them developing infections and going into hospital. And what we're able to see is that actually you could get rid of that really dominant bad population and bring diversity back to the gut microbiome. Wow. And introduce bacteria that do lots of good things, because bacteria do lots and lots of good things for you, including repairing your gut barrier and stimulating your immune system and all those sorts of things. And we were able to show that these patients had less inflamed bodies. So normally patients with liver disease, they get inflammation circulating around in their bloodstream, as if they've got a mild cold or a mild dose of flu. These things are circulating around all the time, making people feel unwell and creating havoc in their immune systems.
Imagine having a cold every day.
Yeah. But
that's not nice, is it?
No, it's not nice. But actually, that's what's happening to their immune systems. And what we've been able to show, even in this short trial, is that actually that improves. So the levels of inflammation go down in the blood and go down in their guts as well.
Incredible.
But it was a very, the caveat here was we did a very short study. We weren't looking at long-term outcomes. People can say, well, this is just a short thing. How's it going to change people's lives? So, so this is why we wanted to then move on and take it further by actually looking at it in a long-term trial.
Right.
Over 5 years,
right,
where actually we would see if some of the things that we're doing lead to sustained improvements in their health.
We will definitely talk about where we're going next, but can I just bring us back a little bit? So what was the thinking around FMT and liver disease? Like, had we become aware of the fact that diversity was reduced and these bugs were predominating, and therefore if we change that, we might treat the disease? Was there any animal model studies that had been done that maybe suggested that the liver was connected to the bowel? This kind of thing. How did we build the hypothesis before doing the study?
Well, believe it or not, and I love a bit of history. So Ivan Pavlov, who was the Nobel Prize-winning scientist who was famous in 1904 for getting dogs to salivate to the sound of a bell, actually did...
Sorry, 1904.
1904.
Oh, a wee while ago then.
A wee while ago, yeah. But
we're in Glasgow, a wee while. Yeah,
a wee while. But what's amazing is he did lots and lots of work back in the late 1890s looking at the relationship between your gut and other organs of the body. It was beautiful, beautiful research. And one of the things that he was one of the early pioneers to do was to link the gut and the liver and how they talk to each other.
Okay.
And what he was able to show is that when you cut the gut off from the liver, and the gut, things that are going on in the gut go straight into the circulation without the liver bypassing and kind of policing things, so you create havoc.
The gut's usually connected to the liver.
Yeah, so you have a big vein that takes all of the blood from your gut to your liver, and your liver has a really, really important job of effectively cleansing that blood. It takes all of the good things out, all of the things you've eaten for dinner. It cleanses the blood, takes all the bad things out, and then is involved in using lots of different things that we've ingested, the amino acids and proteins and building blocks and vitamins to do all the things that our body needs to do.
Got it. So these people that do these cleanse programs, I mean, if you've got a liver and it's working and you've got a pair of kidneys, you kind of don't really need
We're never going to do a better job
exactly.
than a healthy liver because it's programmed to do exactly that. It's so important in so many things, and they worked that out very early. And then they worked out that if you take the liver out of the system, then you get this havoc because things are not being policed and are going around the system. And actually, it was Ivan Pavlov that first described that liver disease has a really bad impact on the brain.
Oh wow!
Yeah.
Fascinating.
Yeah.
So he was way ahead of his time.
He was way ahead of his time.
Incredible. So that was the start. And then since then, we've started to build the case more and more based on Prof. Pavlov, Dr. Pavlov, Mr. Pavlov.
Yes, Mr. Pavlov.
Ivan Pavlov's pioneering work in
1904.
It's incredible. I mean, I love the history.
Yeah.
We've been doing FMT, INT for how many thousands of years? Going back to
since
ancient...
4th century China.
4th century China, exactly. And only now, however many hundreds, thousands of years later, are we actually starting to apply it to liver disease. We've had people on here talking about inflammatory bowel disease. We're going to speak to people about IBS. We're speaking to people about multiple sclerosis and so on and so on. Maybe obesity, although that's a bit controversial. It's incredible, absolutely incredible. And you're doing really pioneering research into this field. And we're going to talk about the study that you're about to do. But let's go back a little bit again. So what have we kind of done in a high level since Ivan Pavlov? How's the story built for liver?
How's it built? It's a very, very good question. So we've learned that the gut's important, okay, right. And that you can't look at the liver without looking at the gut. They kind of come as a package. Is the best way to describe it. Got it. And I've realised as somebody who does a lot of research into liver disease that's important. So we've started to look at the gut in a lot more detail, and particularly the gut microbiome. Because there are more bacteria in your gut than there are stars in the universe, or grains of sand on a beach.
Amazing.
Just to give people a perspective of a lot of bacteria. And those bacteria, when they sit together, can do some pretty powerful things, if you can imagine. Right. And so we've started to understand that actually, if the gut microbiome becomes unwell, becomes diseased, something goes wrong, then it has a huge impact on what goes on in the liver.
Right.
Yeah. And one of the things that we've particularly learnt over recent years is that when you look at the types of bacteria in the gut microbiome, that actually you lose what we call diversity, which means that you get still the same number of gut bacteria, but you get less variety, I think, is a good way. It's like having a box of Quality Street, but only having 2 flavours. I
love that one.
Yeah. You know what I mean? And they're not the flavours anyone likes. Yeah. Okay. They're the ones that get left at the end of Christmas.
I know exactly what you're talking about.
And actually, what we want is we want a gut microbiome that's got a box of Quality Street with all of the different flavours together, working together, because they all work together in unison to create this kind of perfect environment that allows so many things to happen. And one of the most important things that your gut microbiome controls is your immune system. And that's because your gut is actually a barrier to stop things from the outside getting in, things that you eat. So, when you eat or drink something, it will have bacteria in it. Most foods and drinks do.
Just about to say, it's probably, it's not sterile, is it?
Yeah, it's not sterile.
That's going to freak people out, I think, a little bit.
But
it's the truth.
But germs can be good as well as bad. So
True.
And one of the things we've all just lived through COVID. And this is a really good example. We've all lived through COVID where we've been alcohol gelling our hands and wearing masks and absolute sterility, everything. But what's happened is actually we've exposed our bodies to less bacteria and less germs over the last 2.5 years. So actually, what my colleagues are finding is that in young children, babies and young children, their immune systems may not be developing in the same way that people who lived, long before COVID are, because they're not being exposed. So they're, children, babies before would crawl along the floor and eat dirt and actually that was fine. That's not going to do them any harm, But now you're wearing masks, alcohol gel, and we worry that their immune systems may not develop properly.
Oh my goodness.
And that there may be long, downstream impacts on people's microbiomes, not just in their gut, but actually you have bacteria living on your skin. And if we're alcohol gelling our hands, what's happening to those? We have it everywhere. We have bacteria everywhere.
So without sounding too alarmist or pessimistic, it sounds like the worst may still be on the horizon when it comes to the impacts of COVID or that pandemic period. So what are they finding? Are they it's under wraps at the moment?
Well, it's not so much under wraps. It's just that, no one's seen a study through because, no one's followed up children who were born in early 2020 through to now. Got it. But it's interesting that there's been a delay in the usual childhood kind of illnesses that children get. They haven't had as many coughs and colds and things like that, for example. Yeah. And actually having infections is also good for you because it encourages your immune system to develop. Yeah. Yeah. And that's and to deal with things.
So interesting, Debbie. So interesting. So back to the liver. Maybe a bigger question, like what kinds of liver disease are there in kind of big buckets, if you like? There's like infections, body can attack itself. Then you've got cirrhosis, which people will have heard of. Maybe we'll start with cirrhosis because that's relating to your studies, right? So what is cirrhosis and how does it happen?
Yeah, so cirrhosis is a condition where it results from basically cirrhosis is scarring of the liver. You get a very scarred, shrunken liver, and it's the result of a damage to your liver over a number of years. And sometimes it's not a short period, it's maybe 10, 20 years. And the typical things that will damage a liver that people will, I'm sure, be familiar with is drinking too much alcohol. One of the top causes, probably the main one in Glasgow.
Is it is it the top though around the world, or are we seeing other? You're going to go on. Sorry, I'm stealing your thunder. Sorry, no, you go.
So alcohol, fatty liver disease, and if to put this in context, 40% of the world's population now has a fatty liver. 40%, and fat sitting in within your liver. In some people, they just have fat sitting in the liver, and it stays that way. But there's a smaller group of people, about 7% of the population, where that fat irritates the liver and causes the liver to become inflamed and scarred. So about 7% of people will go on to develop inflammation in the liver and scarring and cirrhosis. And the biggest cause of liver disease globally in times to come will be fatty liver disease. It's certainly the biggest cause of liver disease in Western populations.
Incredible.
If we look at people that causes liver disease more in the developing world, viral hepatitis is still a very prevalent. So that's hepatitis B and hepatitis C. And if I was to tell you that 350 million people in the world have had hepatitis B.
Oh my goodness.
Of which large proportion.
I'm familiar with hepatitis B and also familiar with fatty liver disease, but I had no idea that the figure globally for fatty liver was that high. Was blowing my mind. Yeah. And also I had no idea that the number of people that had or have had or have Hep B is that high. Yeah. That's huge.
But of course, in the Western world, we've developed vaccination against hepatitis B, and we can effectively cure Hep C.
That's an incredible story, isn't it?
So whereas hepatitis C was one of the main reasons why we transplanted people in the United Kingdom, it's now way down the list because we're now the top reason for transplanting somebody now is fatty liver disease, followed by alcohol.
So what are we going to do then if it's 40% and we're short of livers?
Yeah, we're short of livers. It's very scary, isn't it? It's very scary. And of course,
that's extremely scary.
Big pharma want to develop a pill that people can take to make them skinny and get rid of their fatty liver disease. But we know that's not going to be the answer. No? It can't be the answer.
But what is the answer? Is it a microbiome therapeutic? Obviously, I've got a bias.
Yeah, it could be.
It could be.
But it could just be about us being sensible about looking after our guts.
Yeah. This is maybe a philosophical question, but the scarring in cirrhosis, I think it's typically described as irreversible. Mm-hmm. Do you believe that? Or is there a way of going back and salvaging?
It is pretty unreversible. However, we believe there's possibly a component that is, because even in somebody with a scarred liver, you've got liver cells that sit between a scarred liver, and you can have unhealthy liver cells or you can have healthy liver cells. So if you've got somebody, you're not going to take the scarring away, but what you can do is encourage the liver cells between the scarring to become more healthy.
Got it.
And then that will automatically improve patients. There is a suggestion that maybe in patients that were treated for hepatitis C that were cured, there were suggestions from some studies that the scarring was reduced. But actually, in the longer term, we're still seeing that these people have increased rates of things like liver cancer.
Okay.
So maybe it didn't reverse it as much as we thought.
Wow. So just on the Hep C side then, so it's someone developed a cure. Like, what did it do? It just stopped the virus replicating really well, or?
Yeah, so initially when we wanted to treat hepatitis C, we used to give people these horrible interferon injections that gave you flu, basically. Interferon is the substance that circulates around your bloodstream when you've got flu and makes you feel absolutely lousy. It makes your muscles ache. It makes you feel awful. But interferon also helps stimulate your immune system to clear a virus. So when you have flu, it's the interferon circulating around that's killing the virus and helping you to get better. Oh. So what we did
So is that why people feel bad when they have a flu?
Yeah.
It's for the interferon?
Yeah, it's the interferon circulating. So what they did with hepatitis C is we used to give people interferon injections to help their immune systems to try and clear the virus. And in some people it did, but it was a very small percentage.
Can I take us on a tangent? Yeah. I'm very interested in something called longevity. So you've got your lifespan, you're born, you die, and then you've got your health span. How many of those years are you healthy for? There are various weird and wonderful, some may be effective, some not effective approaches to increasing your health span. Is giving yourself some interferon, even if you feel a bit lousy, some way of enhancing your sort of defences against viruses, or is that a bad idea?
Well, it did. That was the whole idea of giving it. It enhanced your defences and it helped you clear hepatitis C. But the problem was that it made people very unwell, very sick, and you'd have to give this treatment for up to a year, anything between 6 months and a year. And patients would have to go through all of this. It was awful. And then, pharmaceutical companies then developed antiviral medications, a little bit akin to how we treat HIV now, with tablets that were contained antiviral agents that actually would directly kill the virus. And that's how we've eradicated hepatitis C now, in that we've got very, very effective tablets that contain antivirals that kill the virus very rapidly, so that patients might only need a 12-week course of these tablets and then the virus is gone. And that's changed the landscape beyond, all recognition now for viral hepatitis.
Incredible. Is the same coming for Hep B?
Yes, basically. So hepatitis B, they've traditionally always used antiviral medications, but again, they would lower the level of hepatitis B in the blood, but they wouldn't get rid of it completely. So some of it would sit dormant in the liver and in cells. Whereas now we're developing medications that actually will eventually, I'm almost certain, start to cure people of the virus. And
super cool.
Yeah, it's super cool.
What do we do about these patients with the fatty liver then? What's the future there? Is it the microbiome? Because it feels like it probably is. a little bit to do with the microbiome, isn't it?
So I think that we've got to think also about these people with fatty livers have fat elsewhere. So these are people who generally often lead very unhealthy lifestyles for whatever reason. That they're overweight, they have increased risks of heart disease, they have increased risks of stroke, they have increased risks of cancer, they get fatty liver disease, high blood pressure, all of those things. So the thing to remember about people with fatty liver is it kind of comes in this package of what we call in the medical profession metabolic syndrome. Diabetes is the other classic thing that joins all of these things. So we believe that the gut microbiome is important in the development of the metabolic syndrome and fatty liver disease, but it's not the complete thing. There's definitely a genetic component. If you have skinny parents, you're more likely to be skinny.
Right.
Yeah. It just it's a fact of life.
Yeah.
If you have overweight parents, you're more likely to be overweight.
Yeah.
It's about how much activity you do. It's also crazy things like people who work night shifts.
Yeah.
Are more likely to be overweight than people who don't.
Yeah.
Because actually working at night is a stressor. It releases adrenaline.
Yeah.
That makes you eat more and makes you more likely to put on weight. So there's loads of crazy things we do in our lives that dictate whether we're fat or thin. But also all of these things also affect your gut microbiome. So if we take it back to the gut microbiome, your gut microbiome controls your appetite, for example. So there are bacteria in your gut that will release hormones that will dictate whether you're hungry or not.
Whoa.
Is a good example, but so many other things. On your gut microbiome actually breaks down things, it metabolizes things, and actually, if you have a really, really good gut microbiome, you can actually burn calories quicker than if you've got a bad one.
Wow, amazing!
That's another, just some really simple examples.
Incredible.
And we know that there's lots of things. So I've said sleep affects your gut microbiome, exercise affects your gut microbiome.
Yeah,
all sorts of things.
Doing the night shifts probably does affect your microbiome. I did read some research from a French group that talked about the circadian rhythm of the bugs. They don't go to sleep, I don't think. No. But there's something there. I don't fully understand it. So liver cirrhosis then. We mentioned that these bad bugs appear and the diversity goes down. In the animal studies that we've done, is there a similar kind of picture? Like are the humans studies saying a similar kind of thing to animals? And what happens to animals if they're bred without any bugs at all? Like, do we struggle to give them liver disease?
So if you have they call a germ-free animal, so they've eradicated, they don't do very well, they die. They die very early because you need your gut microbiome to survive. It's really, really important, your gut microbiome. So you can have these germ-free animals, but they don't do very well. Right. You need a gut microbiome. It's kind of vital to life.
Fundamental.
It's fundamental, absolutely.
Even though we can't see it.
Yeah.
We need it.
We need it.
Okay, so we talked about your profit study, and that sounds like it was a success. It seemed to be safe. Patients who took it tolerated it quite well. And importantly, for the future, you saw some changes in the microbiome. So diversity went up, and then that correlated with markers of inflammation.
Yes.
And you also measured something that the bugs produce called ammonia, right? Mm-hmm. And did that change as well? Yeah,
so ammonia is basically a toxin that patients with liver disease have high levels of. And ammonia is a horrible chemical. We add it to toilet cleaners. That's how horrible it is. It's a nasty substance.
And we make that in our body?
And we make it in our bodies.
Oh dear.
Okay. But normally our bodies have very efficient ways of dealing with ammonia. And guess what? Your liver is the organ that gets rid of all your ammonia. It sorts it all out, and it takes the ammonia and it packages it either into amino acids, which we need as building blocks, or it gets rid of it in something called urea, which we then pee out. So liver normally deals with it. But in patients with liver disease, ammonia levels build up. And we've learned that some populations of gut bacteria produce a lot of ammonia.
Right.
It's a byproduct. But normally in health, that's not a problem because your liver says, right, I'll take that off and deal with it. But in patients with liver disease, if levels build up, it makes them unwell. It affects their immune system, particularly, but it also affects their brain.
Oh.
And patients with liver disease get this condition called, very long word, encephalopathy. And that basically means a kind of a sick brain. It comes from a Greek word which means a sick brain. And what we were able to show in our study, and it was only very preliminary data because it was a small, short study, is that ammonia levels in these patients went down.
Oh.
So that might suggest that there are certain, that we're getting rid of the bacterial populations that produce a lot of ammonia and replacing it maybe with populations that produce less.
Wow. So that could be transformational for the future.
It could be, yes.
How big a problem is this encephalopathy?
Oh, it's a huge problem. So with people with liver disease, with liver cirrhosis, so that's scarring of the liver, up to 80% of those patients over their lifetime will develop this encephalopathy. And encephalopathy is a horrible condition because it's a bit like dementia. It's a bit like having Alzheimer's. It affects your short-term memory. It affects your ability to concentrate, to do all sorts of things. And it's a horrible, horrible condition. It's so debilitating.
It must be a big deal for patients with cirrhosis to maybe do a bit of reading themselves or speak to their hepatologist or the liver doctor. And they say, one of the things that probably is going to happen at some point is your brain's going to stop working properly. That must be quite daunting for them. So what do we do for encephalopathy at the moment? Like what have you got in your toolkit, if you like?
We don't have a lot, I'll be honest with you. But some of the things that we do use to help patients with encephalopathy actually relate to the gut microbiome. So the primary treatment that many patients get with cirrhosis encephalopathy is they're given this sugary syrup called lactulose. And sugary, it's basically a prebiotic, and that means it's something that the gut microbiome can actually use and break down. And what happens with the sugary syrup is it basically changes the environment in the gut and helps to for the bacteria to produce less of this ammonia stuff. So that's our main treatment. But the trouble is it's a sugary syrup that also makes you want to go to the toilet a lot.
Oh.
And so
how a lot?
Oh,
a lot.
So
Right.
People are it makes them gives them diarrhea effectively.
Okay.
Which is quite unpleasant. Not great. And so people don't enjoy taking this stuff, but
for obvious reasons.
They will
living on the top. Just out of interest, I mean, is it prescribed to get people to go to the loo sometimes in other cases?
Yeah, it is. So it can also be used for constipation.
Right. So you're essentially taking a laxative.
So you're taking a laxative, but it's a laxative that also does things to your gut microbiome.
Got it.
To reduce ammonia production.
Got it.
And then the other types of treatments that we've got at the moment are antibiotics, and there's a particular antibiotic that we use at the moment called rifaximin.
Right.
And rifaximin is an interesting antibiotic because it's not when you take the antibiotic, it's not absorbed into your bloodstream like many other antibiotics that you'll get for if you take if your GP prescribes you an antibiotic for a chest infection or a urine infection, it will go into your circulation. This stays in your gut. And rifaximin, again, probably alters the populations of bacteria in your gut, which ultimately leads to less ammonia accumulation.
Got it.
But we think also that rifaximin as an antibiotic might also do some other things. It might improve things like your gut barrier. But people are only really starting to explore this because rifaximin has only been on the market for about 10 years.
We've talked about the gut barrier a couple of times. Should we just work through that a little bit? What is the gut barrier and why is it important?
So the gut barrier is basically a layer of cells that sit between all of those bacteria that sit in your gut and all the food that you eat and everything else that's there. It's basically a layer of cells that protect, that divide your gut microbiome from everything else inside you, your intestines and all of the things. And it's actually a very, very kind of robust barrier. It doesn't normally let things in and out. It's very, very tight. But one of the things that we know with people with liver disease is that actually that barrier might become more leaky. And actually, it's not just liver disease. Actually, it's probably people with inflammatory bowel disease and other diseases that may get this more leaky gut. And so what happens then is if your gut's a little bit more leaky, things can pass across. So some of the bacteria in that are really designed to stay in your gut where they need to be, they can actually pass through into your bloodstream.
Wow. Okay, that seems pretty important. And does that cause inflammation? Yeah.
So, obviously you've got bacteria in the wrong place, and then your body says, oh, I've got a bacteria in my blood. I need to fight it. Yeah. It releases lots of substances to fight it, including like interferons that I mentioned to you, but lots of other lovely substances that normally help to control things. And you basically, your body is continually fighting these bugs passing across. And most of the time it does a good job of fighting them, but every now and again it doesn't quite fight them enough, and then our patients develop infections.
They get sick.
Do
the bugs go to the liver? Like, do we find bugs in the liver?
Yeah, we do. So the bugs can actually pass into the big vein that carries blood from the gut to the liver.
The one we spoke about earlier.
Yeah.
And then that causes inflammation in the liver, right?
Yeah.
Goodness me. And I suppose sometimes, when people die, we examine body parts and so on. Can we measure like bugs in the liver of someone that's passed away who had cirrhosis?
You can. I mean, this has mostly been done in animal models because for the difficulties of doing anything on somebody who's sadly passed away. But yes, you can actually find bacteria in lymph nodes, lymph glands as well. And in the liver and in the portal vein. Or if it's not the actual bacteria itself, it's the bits of broken down bacteria where you can see that their immune systems have started to deal with them.
Incredible. Yeah. I went to med school. It's a little while ago now. We didn't get taught any of this. There was nothing on this. But it's sounding like it's fundamental. If that barrier is leaky, and the bugs are just going everywhere, and goodness knows how many other conditions and diseases they might be contributing to. So if you've got encephalopathy, how bad a situation is that, and what happens afterwards? Is it... I can see on your face it's pretty bad.
Yeah, it's pretty bad. So it kind of has the same prognosis as having dementia, just to give people context. Yeah. Goodness so, it will only really get better. It will only really go away when liver disease goes away. So if if you had a sick liver and encephalopathy and I was to give you a liver transplant and give you a new liver, it would go away. But if you're somebody who isn't receiving a transplant and you've got that sick liver in you, it's never going to go away. It's always going to be there. And unfortunately, the prognosis when you have encephalopathy is very bad. Only about 30% of people are still alive after about 3 or 4 years.
Wow.
Yeah.
And is there a spectrum of encephalopathy?
Yeah. There is. As with anything in life, you've got very mild type of encephalopathy where people might just be a little bit slow, not quite on the ball, but they can still carry on with their lives. Then you've got other people who are literally moribund and almost comatose in hospital.
Whoa.
Because the levels of the ammonia and the toxins in the bloodstream are so high that the brain begins to swell.
Wow.
And that's often not,
that sounds terrible.
Yeah.
So we've talked about ammonia, which the bugs produce. Do the bugs potentially produce other things other than ammonia that might be contributing to this as well?
Definitely. So every bacteria will have a job of producing various things depending on the type of bacteria it is. And some of these things are good things, as we talked about. Some of these things are bad things. And actually, even bacteria producing ammonia, if it's part of everything going on in your body, that can still be a good thing. But, if they start to produce more of the bad things, and I don't think we have a huge appreciation yet of some of the bad things that bacteria produce. We can measure things in the bloodstream, but we don't know really, what is good and what is bad. Right. And sometimes actually everything's okay. It's just as long as it's in the right proportions. And I think the trouble with people with liver disease is things get out of proportion.
Right. And there's too many of these bad bugs.
Yeah.
Is it fair to say that these infections by bad bugs that live in the gut are a major cause of death in patients with cirrhosis as they get sicker?
Yeah. So you can link the sicker your gut microbiome, the more likely you are to get infections, the more likely you to be in hospital, the more likely you are to die.
Wow.
And there's a very, very close relationship.
Wow. So there's a story building here. You know, patients so before cirrhosis, they've got fatty liver or other things, which probably change the microbiome. Then they've got cirrhosis, and the sicker they are with cirrhosis, the sicker their microbiome. So I guess that brings us to what can we do about the microbiome? And we spoke about rifaximin, but if patients are still getting sicker and sicker, it can't be, you know, an incredible option. It's not like this drug for Hep C where everyone's getting cured. So I suppose that brings us back to the FMT.
Yeah.
What are your thoughts around how that might fit into the future, and what are you planning for your next study?
So we did this early kind of pilot study that we talked about, the Profit study. But, you know, the criticism is that, you know, you've got to show that this is going to impact patients in the longer term. We can't just have a quick fix, you know. So basically, with the pilot data that we got from the study, I basically approached the NIHR, which is the main funding body in the UK for really, really important clinical trials and clinical research. And I said to them, look, we've got this data. We should look at this in a big trial. Okay. But it's going to be a very expensive trial. Because it's big, but we need to look at this. And actually, we can do this almost in a way that's more efficient than any kind of commercial developer of treatments, because we can use the NHS and our network and our patients and do this. And so during the COVID lockdown, I put together an application for a trial that we've called the Promise trial. And the idea is that we want to treat patients with two types of liver disease, actually, alcohol-related liver disease and cirrhosis, and fatty liver disease, because they're the two biggest groups that we manage, but they're also the groups that we know have lots of leaky gut and lots of changes in the gut microbiome. And so we wanted to look at these. And so I put in an application where we want to treat these patients for 2 years with FMT versus a placebo, because I explained why giving a placebo is so important. And what we want to do is actually now look at clinical outcomes.
Okay.
We want to look how many infections they get, how many times they're admitted to hospital, how many other bad things happen to them, and look at that over that 2-year period. And we're going to enrol 300 patients. Wow. So 150.
So how does that compare to all the other studies that have been done to date in liver?
Well, this will be the biggest global trial of fecal microbiota transplantation in liver disease. I'm sure others will follow. But
well, I might go a step further. I am not aware of a study that big being done for any indication, maybe C. diff by the drug developers who are doing it, like Cirrhosis and Probiotics. So this is, I keep saying very cool. It is actually very cool. This could be transformational for the field, right?
That's what I'm hoping. I mean, and so we've had to look very carefully at how we do this and how we plan this and how we're going to include patients, because putting together a good clinical trial design is really, really important, because if you put a bad one together, we're actually letting our patients down. We're not letting anyone else down. We're actually letting our patients down because we've not picked the most appropriate way to test something. So we've had to think very carefully about how we're going to do it. And, I've had to persuade the government to give us £2.5 million to fund this during COVID, which was, I think probably one of the hugest achievements I've had to date is actually persuading, somebody to give this kind of funding. And we're going to see what it shows. We're going to see what it shows.
So what are you going to be measuring in terms of microbiome, and how much of the drug are they going to get? Are you dosing every day?
Yeah. So
every 7 days?
So as I mentioned in the Profit trial, we used to give the FMT via an endoscopy, which is quite an invasive traumatic thing to have happened to you.
So it's basically a tube that goes down your
throat. Yeah, and not everybody's a big fan of that.
No.
And so, as with all trials, we talk to our patients and we say, and they said to me, Debbie, wouldn't it be great if we had this FMT in a tablet I could take with all my other tablets at breakfast or whatever. And so I work with a fantastic colleague called Simon Goldenberg at St Thomas's Hospital. And actually together we have set up a fecal microbiota manufacture unit, which we funded together again from a Wellcome government grant, actually, a Wellcome Foundation grant. And we've actually made FMT capsules that actually contain the equivalent of about 80 grams of stool.
Wow.
And in our profit study, in the 200 mils we gave, there was only 50 grams of stool.
Wow.
Now we give 80, that it's freeze-dried in a capsule, so that actually we will give our patients 5 capsules of the treatment. Now, what's great about FMT is once you give it actually lasts for a while. It lasts for a few months, Right. It does start to wane.
Right.
We know that from my early trial, the effect started to wear off, but it lasts for 2-3 months. So what we decided with this trial is that actually we were only going to treat our patients every 3 months. So what's going to happen is they're going to be redosed every 3 months for 2 years.
Love that.
And so they only have to come once to the clinic or the hospital in 3 months to have their 5 capsules, and then off they go. And obviously we will be in close contact with them, follow them up. And what we want to do, apart from looking at the impact on their health from perspective, is that we're also going to be collecting samples from them. We're going to be collecting their blood and their stool and things, and actually looking to see if we can understand what things are happening, good or bad, of course, so that we can try to understand where this might be beneficial.
Got it. What is the vision? What do you think? I mean, you can't predict the future.
Yeah.
You must have some hypotheses about this and almost like what you're hoping to see.
Yeah. So obviously I don't want a negative trial, not for my sake,
sure.
but actually for the sake of my patients more than anything.
For sure.
Because we all do this for the patients.
For sure.
So if this is a positive trial, then what will happen is that because this is a government-funded trial, NIHR badged, basically we would, if this was a positive trial, we'd need to look that this will become standard of care.
Wow. For patients with cirrhosis.
Patients with cirrhosis.
And that sounds good, because going back to earlier in the conversation, we're talking 40% of the world, 7% of that 40% getting cirrhosis. We need new options.
We do need new options.
So is the thinking there you might slow down what's happening, stop what's happening, in terms of they're not going to get encephalopathy? Like, what do you think might be what would be the ideal outcome, I guess?
Well, the ideal outcome, the sort of main outcome that we're what we call powering the trial on, which means that we will look at to decide if it's a good treatment or a bad treatment, is that we're going to look at the amount of infections the patients get that result in them being hospitalised.
Yep.
So normally when you have cirrhosis, you're very prone to getting an infection, which takes you into hospital invariably, and you have to have lots of intravenous antibiotics, and spend 2 weeks there and be very sick, and hopefully you will get home, but not everybody does. And so what we're going to look at is to see the impact of the FMT on infections and hospitalisation, and that's going to be the main judge of whether this is a good thing or a bad thing. But we're also going to be looking at all the other complications that you get of liver disease, like encephalopathy, but also there are complications that include things like bleeding, because when you have liver disease, you're more likely to bleed.
Why is that? Because
you get these varicose veins in your gullet and your stomach that result from a build-up of pressure in a scarred liver, and they can bleed.
Okay.
They can bleed, and also patients get very distended bellies because they get fluid accumulation in their bellies. We call it ascites, but they often, grown men walk around looking like they're 40 weeks pregnant with fluid, and we're also looking at things like that. So we're looking at lots of other things that happen to cirrhotic patients. We're also going to be looking at their quality of life.
Right.
So they're going to tell us if they feel better or bad. We're going to look at the impact on depression and anxiety as well.
Oh, Is there a link between cirrhosis and mental health and the gut and the brain?
Yes. So you have a big nerve that connects your gut to your brain called the vagus nerve. Okay. And it also has branches that connect to the liver. And we think that there's this gut-liver-brain axis. And so that some of the things that go on in your gut and your liver might also determine what go on in your brain. And we know that patients with liver disease are more likely to get mental health problems, particularly depression.
Really?
Yeah. It's far more frequent.
Wow. In terms of statistics, is there any numbers we can put on it?
So about 40% of patients with cirrhosis will suffer from depression.
Wow, that's high.
And it's
really high.
And what we don't know is whether it's related to maybe some of the toxins that are going around, or whether actually it's another process. But one of the things we're going to look at in this trial is in a sub-study of this trial is we're actually going to look to see how happy and anxious our patients are in the trial.
Incredible.
So we're working with the Maudsley Hospital in London, looking at that as well, and that's going to be a sub-study which we're going to call Transcend. Is the nickname? The
Very
Transcend
nice.
Study.
This is cool. There's a lot of cool naming nomenclatures in there. Prophet, Promise, Transcend.
Yeah. Oh, you need a name.
I mean,
Me.
Ours is called Impulse. There's a bit of fun there, isn't there?
Yeah. You've got to come up with something.
Has anybody ever done any work on what happens to mental health after FMT, or is this very new?
It's very new.
Yeah.
It's very new, and there are some studies. Led by neurologists and psychiatrists who've looked at inflammation in the brain and the relationship with depression. And this is not in people with liver disease. This is just, somebody comes along with depression and they look for inflammation in their bodies, and they see inflammation in the bloodstream and they see inflammation in the brain. And I guess the question is, where's that inflammation coming from? Right. Could it be coming from their guts?
Probably could be, if they've got a leaky gut. And I've also seen in animal models you can transfer an anxious phenotype. So the sort of, in animals it's different, right? Because they can't say, not feeling too good today, there's various different things you can do, like how long they struggle for and things like that. I won't go into detail. But what's been shown is you can move that depressed phenotype from one mouse to another mouse. You can move an anxious phenotype from one mouse to another mouse. And that really is quite incredible, isn't it? Because some of these mouse can be born germ-free. So all they're getting is the microbes from the mouse that's feeling depressed. And they've also taken, I think, samples from humans who are feeling like that and moved them into mice, and the mice get more depressed. So something going on there, isn't there?
Yeah, so we thought, as we're doing this big trial, why not look at it at the same time? Because it's very easy to do. It's very easy to do.
So I'm a glass half full kind of guy, the eternal optimist. I think you have to be when you're, trying to create something that no one else has ever done before. But it could be the case that in the future, based on this study, patients will be prescribed 5 capsules every 3 months for the cirrhosis to stop it getting worse. And maybe, and I know it's speculative, they also benefit from whatever's going on between the gut, the liver and the brain, and they feel better.
Yeah.
That's a big deal.
That's a big deal.
That's a really, really big deal. I'm very, very excited. Very excited.
And there's one more. One more big deal.
There's another big deal. Yeah. Okay.
So one of the other things that you see in patients with liver disease in their gut microbiome is they have bacteria that are resistant to antibiotics. And many people might have heard of this term, antimicrobial resistance. And the World Health Organization has said that basically the threat of antibiotics no longer working is one of the top 10 threats to global health. It's a huge problem.
And we've spoken a lot about big problems today. But we've also spoken about big solutions. This is a big problem, isn't it?
In our Profit study, we found that 25% of the people that were in that study had these antibiotic-resistant bacteria in their guts. Okay?
Whoa.
Yeah. And actually, when we gave them the FMT, those antimicrobial-resistant bacteria went away.
Wow. How? The bugs are just out competing them and
so
stimulating
the healthy
system,
populations just rein them in.
They rein them in.
And they the good guys overpower the bad guys.
Get out of here, guys.
And you restore balance, I think, because I think sometimes these antimicrobial resistant bugs, that it's because you've lost balance. And we showed that you could get rid of the antimicrobial resistance. This
is incredible. And maybe there's some element of you put the good bugs in, the immune system sort of turbocharges a little bit, and then they can start booting the bad ones out as well. So interesting. So in addition to all the other benefits, we might be doing some good in the form of reducing AMR resistant bugs in the gut too. So this is incredible. Good. So can you say when it's going to be starting, or is that still confidential?
No. We've submitted our ethics application. So any clinical trial, even if it's funded, has to go through has to be reviewed by an ethics panel. The ethics has been submitted. So if the ethics review says it's favourable and that they're happy that it's not going to, they have no concerns that it's going to damage patients in any way, then we will be able to start very shortly. So we've got a date potentially of the 1st of November, but it depends on how long the ethical review takes.
This is very exciting. Can patients contact you, or it's not like that? You've already got a list of patients you're probably going to contact.
Well, they can contact us. We have a website. We have a Promise Trial website, and we have a Promise Trial manager. And actually, patients can contact us through the website and through the trial manager.
Is the website live now?
Yes, it is.
What's it called? You don't know.
It's called fmttrials.org is what it's called.
Is it?
Yeah.
How did you get that one? I thought I had all of the good FMT domains.
No, well, fmttrials.org.
You and Simon, man, you've been taking my domain. I'm joking. Oh, here we go. There it is.
That's it there. So yes, so you can and you can see that we've got the Promise trial there. But we've also Ferraro is a trial that my colleague Simon Goldenberg is doing.
You are very good at this creativity thing.
And we've
Promise, Ferraro.
And we've also got a great animation on our website that tells you all about the gut microbiome and how important it is.
Oh, this is cool.
A 7-minute animation that people can watch.
This is really cool, guys.
And you can even, on the site, on the homepage, you can go to, you can even register to be a stool donor.
This is really, really cool. It looks really good, Debbie. It looks really, really good. Congrats. And congrats on getting £2.5 million roughly from NIHR. It's not easy to secure that level of funding, is it, for a novel therapy?
No.
This is very difficult. So congrats. So Simon's involved in this. We'll need to get Simon on. Yeah, we'll need to get Simon on. So Ferraro, is this something you're doing, or is this something Simon's doing, or both?
So I'm involved, but Simon's leading on it. So for the Ferraro trial is a trial looking at using fecal microbiota transplantation to cure antimicrobial resistance. So he is looking. He treats very sick people with all sorts of different things. It's not. Many of them have cancer.
He's a bit of a pioneer, isn't he?
He's a pioneer, but they get horrible infections, and sometimes it's not the cancer that kills them. Sadly,
it's the bugs.
It's the horrible infection they get as a result of the treatment. So he's treating them with, again, in a trial of FMT versus placebo, and looking to see if he can cure those horrible bugs.
Wow, amazing! There's a lot of great work happening here in the UK.
There is, really, and I think I'd say we were leading the field.
I think so as well. Well, some might disagree. There's some very passionate people elsewhere, and I'll say no more. But I shall say no more.
I'm biased.
I'll say I'm biased too. Go Team UK. Yeah. On another related but slightly tangential, if that's even a word, note, coffee and the liver.
Yeah.
What's the story with coffee and the liver? Because we've had people on this podcast who advise cutting down on coffee. But it sounds like there might be a liver benefit and a microbiome benefit.
So some studies were done in animal models, but then later sort of taken out into good old humans and patients that's looked at coffee consumption and liver disease. And basically, we've been able to show that coffee, if you drink coffee, I'm not talking about having it infused, but if you drink 4 or 5 cups of coffee a day, you're actually protecting your liver.
Wow.
So there's something in coffee, and we don't really understand why, because it doesn't translate to tea or other caffeinated drinks. It's something in the coffee or the coffee bean that's protective of the liver, and may even actually protect the liver against becoming fatty and inflamed.
Really?
So I like drinking coffee, and now I'm happy that I'm doing good things for my liver. And actually, I encourage my patients to
drink coffee.
To drink coffee.
Now, the question, I guess, is how much coffee does one require to get the protected benefits?
Yes. So, basically the relationship was shown to be that the more coffee you drink, the better. But probably you get to a stage where it probably has detrimental effects for all sorts of other reasons. Yeah, because you're around
shaking like this. But
it's okay to have 4 or 5 cups of coffee a day.
Oh. I mean, that's a lot of caffeine.
Yeah, it is a lot.
That would send me even more wired than I am without any coffee. So that's very, very interesting. Do your patients ask you about probiotics? And should they be taking them, or is it a bit like we don't know what's in these? They
do ask, and you know that the very sad thing about probiotics is that there've never been anyone who's done a really good trial in liver disease. It's really, really sad. And actually, I've approached people who make probiotics and said, let's do a trial. And they've said, no, it's too high risk, because if it's a negative trial, we'll lose our business. So I've never been able to get anybody to do a proper trial.
That is very, very bad. Just FYI. That is very bad.
That is very, and I'm not naming names,
Don't worry.
But there's not been an appetite to do it. So the trouble with probiotics is a lot of the evidence about benefit in liver disease is kind of anecdotal.
Right.
And a lot of the early studies where people have done some sort of study, they've used antibiotics that often get killed by the acid in the stomach. So, somebody takes a capsule, it's broken down by acid in the stomach, and actually you can't really perceive there to be much benefit. People with using some of these bio yogurts, and Yakult sponsored a study where they looked in liver disease patients, giving them Yakult to see if it improved things. There was a little bit of benefit, but again, I think you actually have to have a lot of probiotic to have an effect.
Right. So
not just one yogurt a day. One yogurt a day possibly doesn't solve the world.
And maybe to put it into perspective for the listener, like these probiotics maybe have 1, sometimes seen 5 different types of bug in them.
Yeah.
But let's go back to the FMT capsules. There's hundreds, isn't there?
There's millions.
There's millions.
Yeah.
There's millions, exactly. Millions of bugs, probably from hundreds of different species, right?
Yeah.
So it's still orders of magnitude more. Yeah. And that shows you the power of that kind of therapy. So we spoke about cirrhosis. Is there any other potential avenue for microbiome modulation in patients with liver disease that you can maybe foresee? Or is cirrhosis the biggie?
Well, cirrhosis is the biggie, but also we probably want to go back a step or 2 steps or 3 steps, and probably actually we want to see if we can prevent cirrhosis happening. So, eventually I perceive us doing trials where we'll take people who maybe have gone to their GP for the first time, and the GP says, your liver looking a bit fatty on your scan, and actually trying to intervene there before the liver disease has become a problem or even developed, in very, very early stage. That's what we'd like to do. But also we'd like to do some just really simple things like changing people's diets.
Yeah.
So I spend a lot of my time in clinic with people, even with very early liver disease, talking about the role of diet and how important it is. Because, you don't want to have to prescribe FMT to half the world's population if actually people can do some very simple things as well.
I think if you want to make a lifelong commitment to change your microbiome, you're going to have to make a lifelong commitment to change your diet, right?
Yeah.
Because they need the things that we don't need, if that makes sense. Yeah. And going back to what we talked about earlier in terms of the lifestyles people live and so on, I think it does take some getting used to not eating the very calorie dense, micronutrient light processed foods and moving to really almost calorie light, micronutrient dense, fibre rich, colourful type diet. It's difficult, isn't it?
Yeah.
Do you see though that when your patients actually move to that kind of lifestyle and they stick to it, they start to feel so much better, they just decide that that's the way they want to live their life? Or maybe not.
So I've had a couple of patients who really have done radical things, like they've become vegans, for example,
right?
And absolutely done radical things. And I have a patient who was in my hospital for about 4 or 5 months on intensive care, dying of liver disease, and we got him better. We got him out of hospital. And he decided to become vegan. And he's never looked back. So sometimes people can take dramatic interventions themselves. And we know that people who are vegan, they are great stool donors for FMT. They are probably the best.
Because
they have lots of fruit and lots of vegetables and lots of fibre and lots of things that are good for the gut microbiome and have far less processed foods.
Yeah.
Although there is a vogue at the moment to develop processed foods for vegans, which is just...
It's interesting that, isn't it?
All this kind of processed cheese and things like that.
Yeah, I've seen that.
Vegan KFC, things like that.
No, not for me. The concept of what makes a good donor is kind of interesting, right?
Yeah.
At the moment, we're selecting donors really primarily based on kind of, do they come in a lot and are they producing safe material?
Yeah.
That's not trivial.
No, it's not trivial at all.
That's a huge deal and it's very difficult, actually. But do you think that there might be certain bugs that are more important for liver disease effectiveness than others, or is it more just about the diversity of the donation, the health of the donor, and being absolutely sure that there's no bad bugs in that product? See where I'm going?
Yeah, no, I do see it. And it's interesting because everybody's microbiome is as unique as a fingerprint. So even twins, identical twins, have slightly different microbiomes. So it's like a fingerprint. And sometimes you can have 10 healthy people who've got very different microbiomes, but they're still all healthy. So we think it's because it's not about the bugs they have, it's the diversity of the bugs they have. It's the range. It's the having all the different flavours in the Quality Street tin.
Got it.
Yeah. And that's more important than actually one person having some of this and another person having some of that.
That makes sense.
And I think it's about diversity, particularly.
That makes a lot of sense. So in terms of one strain, two strains, two species, probably not really about that. It's because you could have, as you say, 10 healthy people who have all different profiles, but all of them have high diversity compared to a patient, right? So that suggests that maybe the diversity trumps whatever's happening at a more kind of granular level. So at the moment, we're not selecting based on a particular microbiome profile. However, in your study, you're profiling the microbiome before and after the intervention, and you might see certain trends, right?
Yep.
And that might allow us to sort of refine the process a little bit more.
Yep.
One question for you. Some studies are giving their patients lots of antibiotics before the FMT and they describe it as improving engraftment. They're essentially just blasting their microbiome with vancomycin and other things. Is that something you're considering in your study? No.
I think it's a really bad thing.
Yeah.
I think it's a really bad thing because actually antibiotics are incredibly bad for your gut microbiome. They wipe it out temporarily. And I just don't see what there is to gain, because in our profit study, we've shown that actually, and we didn't use antibiotics, it was actually an exclusion to give people antibiotics, is that actually the bacteria engraft absolutely fine without antibiotics.
So you get the benefit and you're not getting this damaging effect. And actually just, obviously we're listening to you on this podcast, but I totally agree with you.
Yeah.
I find it difficult to imagine as a former clinician telling a patient, we're going to give you this drug, but by the way, we need to give you 5 days of this antibiotic. They'll be like, what? I don't want to take that. There's so much education now around the harmful elements and aspects of antibiotics. I just can't actually see it working, because you're going to be going to someone who's trying to make themselves better and say, we're going to give you this new drug, but by the way, a week of this, which might have its own side effects. They're just going to say no. And vancomycin, what about VRE? Vancomycin resistant enterococcus for the listener. It can be which is
resistant to most antibiotics that we have available.
Right. And we screen our donors for it rigorously because we don't want it to be transferred. And what we're saying is, well, we're going to give you this drug that's potentially going to increase your likelihood of a VRE, so that the other drug can maybe get rid of it.
Yeah.
It's just like, no.
Doesn't make any sense.
I don't get it. What about combining diet with FMT? Do you think that might be an avenue for the future?
I think so.
Yeah.
The trouble is it's maybe too much to take on in one trial.
Right.
And actually, I think we need to just do some dietary intervention trials. I think it would be amazing to do that. And, so simple, really. Yep. But, yeah, it would be a next step.
Should we talk briefly, and we're getting close now to the end of our time, should we talk briefly about, if it is the case that all patients with cirrhosis in the UK at some point in time, one day in the future, are going to get 5 capsules every 3 months, the need to collaborate with industry to make that happen. Do you think that that's an essential path forward for the field? Or do you think that there's always going to be kind of local centres doing a bit of FMT for their patients as well? Like, how do you see the future?
I think there's inevitably going to need to be a collaboration. And I tell you why. Because your average NHS hospital is not going to be able to sit there and manufacture FMT till the cows come home. I've got £2.5 million of which I can employ someone who sits there, right, and makes the stuff. And we've got a whole team of people that are funded from this grant making it. Yep. But actually, at the end of the grant, that team go. Right. So how does your average hospital do this stuff? So we're going to naturally need to develop collaborations to manufacture, if nothing else. Yep. And I think that's really, really important to say. And it's interesting because we've been talking around FMT. We've been trying to talk to the government developing policy. And I was at the Houses of Parliament in March at an event where we were talking about how would we roll out FMT across the UK if we could really show this is important, and you're going to need to have a mechanism of setting up store banks that maybe will be joined with blood donation potentially. Right. You've got to find a way of developing a whole framework to sort this all out. And
manufacturing is not trivial, is it?
No,
it's got to be done under very, very rigorous, tightly controlled environments that operate to a quality management system. You need to make sure that the facility is very clean. And if it isn't clean, they need to stop manufacturing. The process has to be tightly controlled. If it's deviated from, you've got to document that and decide if it's had an impact on the product. So it's a big deal.
It's a big deal.
People might think, oh, well, you just collect a stool sample from a screen person and you make it, and that sounds quite short. It's not. It's not at all. And of course, some patients try it themselves. I don't know if any of your patients have considered it or have talked to you about it or have even done it. It scares me.
No, but I know it goes on in the US a lot.
Yeah, it's scary, isn't it? It's scary. Debbie, we're coming close to the end. Are there any exciting, cool things you might wish to finish on? Sorry, I put you under the spotlight now, but this has been a fascinating conversation.
I think we've covered a lot.
We've covered a lot. We've covered a lot. Yeah. Awesome. Well, thank you so much. Thank you very much indeed. Cheers.
My pleasure.